Alaikum wa rahmatullahi wa barakatuh. Good morning, everyone.
Salam.
I'd like to welcome you all to our Emirates Diabetes Endocrine Congress, and this is day 3 of the Congress. My name is Dr. Khaled Aldahmani. I'm adult endocrinologist from Tawam Hospital and also Sheikh Tahnoon bin Muhammad Medical City. I practice in Al Ain, and it is my pleasure today to chat with Professor Shehzad Basaria. Shehzad, you can introduce yourself.
Thank you very much, Dr. Aldahmani. It's great to be here. I'm Shehzad Basaria, Professor of Medicine in Endocrinology at Brigham and Women's Hospital in Boston. I have been coming here for about a decade, and it's great to see how the conference has grown over time. So many attendees, people from all over the world, and it's a great place to share science as well as socialize.
Thank you very much. It's always a pleasure to have you with us, Prof. Basaria.
Thank you.
So today we'll be discussing an important topic, and this is about androgen misuse. I know that this is your area of interest, and perhaps you could tell us in general, how large is this as a problem globally and regionally as well?
I think it is a very common problem globally and growing as well. I think it is important to characterize androgen use, misuse, and abuse.
Yeah.
In terms of use, it is only indicated in men who have organic hypogonadism, such as diseases of the hypothalamus, pituitary, and testes. Misuse means it is being used for medical conditions for which it is not indicated, such as treatment of obesity, treatment of diabetes. And then the category of abuse, where men in general, some women as well, will take supraphysiologic concentrations of androgens, all types of androgens. And the goal there is, in the athletic world, it is to enhance performance. But in the general community, it is mainly to enhance image. The way a person looks, being more lean and more muscular. And this problem is increasing all over the world. In the Western Hemisphere, in the United States, some data which are based on questionnaires and interviews suggest that around 10% of the population, especially younger men, may have been exposed to anabolic steroids at some point in time. Usually it happens in high school and colleges where under the pressure of either performance at the gym or by the coaches, use of these compounds are encouraged. But then of course outside such pressures, just to enhance image, men use it as well. Similar data from Europe, more or less same prevalence based on different geographic regions in Europe. And even in the Gulf, it seems, by talking to clinicians at this conference and otherwise, and also looking at the data, the prevalence has increased in UAE, data from Saudi Arabia, from Jordan, and even from Iran. So it looks like it's a common problem, especially in younger men.
I remember in United Arab Emirates, we conducted a study on the use of anabolic steroid in people going to the gym. And that was almost 2 decades ago. And we looked at the people going to the gym, whether this is a private gym or this is a gym linked to a hotel. And we noted that 1 out of 5 of those gym users, they use anabolic steroid. Now, with this high prevalence, what do you think are the challenges, and what are the, let's say, first of all, symptoms? What are the side effects of these medications or supplements?
Sure. It is interesting that many of the men who go to the gym and even professional athletes or amateur athletes, they are aware of the side effects, but even then they want to use it. Side effects are many, but you can summarize them into 3 different categories. One would be reproductive side effects. The second, I would say, cardiovascular side effects. And the third major category would be neuropsychiatric. not taking into account that there can also be gynecomastia, acne, oily skin. But in terms of reproductive side effects, one thing which we have to be very cognizant of, that men who use anabolic steroids or abuse anabolic steroids are at risk of being infertile. Because when you take high concentrations of androgens, especially for a prolonged period of time, of course your own gonadal axis is suppressed. So when gonadotropins such as LH and FSH are suppressed, they don't stimulate the testes, and that results in dormancy of the seminiferous tubules, and spermatogenesis comes to a stop. So you will see that many men, after prolonged abuse, when they are planning to have children, they are not successful. And sometimes even after they stop and give themselves adequate washout for about 3 months or greater, spermatogenesis does not resume. So that is an important side effect. Of course, the other side effect in the reproductive category is central hypogonadism, which is in a way iatrogenic by themselves, that they have taken it for such a long period of time that their axis is suppressed. And even after adequate washout, since gonadotropins don't reverse, they are not able to start production of testosterone. So androgen deficiency as well as infertility are important reproductive side effects. In terms of cardiovascular, it can cause problems at multiple levels. First is myocardial dysfunction. There are data from Boston, especially from Massachusetts General Hospital, that cardiology investigators have seen that men who abuse anabolic steroids, they have reduced ejection fraction and diastolic dysfunction as compared to men who have never used. Furthermore, in this cohort of men who have used anabolic steroids, some of them who discontinue use, over time, ejection fraction and diastolic function improves. So there is some hope of improvement of cardiac function versus those men who continue to use it. So myocardial dysfunction is one. Also some data in terms of coronary atherosclerosis. That is less robust as compared to the known data on myocardium. Data from Eastern Europe that emerged in the 1970s and 80s, some athletes had experienced sudden death, and on autopsy, their coronary arteries were perfectly fine. It was the myocardium which was thickened. So, effect of androgens on the myocardium, plus because they do resistance training, which also stresses the heart, I think that predisposes them to cardiovascular side effects. And then neuropsychiatric, in terms of high use of androgens, may result in irritability, mood changes, sometimes feelings of anger. So these three are more broader categories, and then there are other categories as well.
Excellent. I think this brings me to another interesting aspect of this issue, is that despite that those people who are using or abusing, let's say, or misusing the anabolic steroids and the androgens, they know about the side effect, but it seems that they have a short-term benefit or gain that's keeping them to continue using the anabolic steroids. How would you counsel or approach them when they come and say, okay, I'm using it for short term and then I'll stop?
I think there are two approaches that one can take. One is what we as clinicians can take, and the other is talking to the policymakers to see how we can influence more on a wider level in terms of restricting the use of these agents. So at a personal level, one-to-one with the patient, I think it is important to lay out all the side effects and inform them that although they think that it is beneficial in the short run for them to look better, look muscular, but what they should appreciate that side effects could occur earlier on as well. And it's a cumulative damage that happens to the end organ system when you keep on taking these agents. So when patients come to our clinic, we do discuss with them all the potential side effects and make sure that they and their family members are aware of what could be the consequences. At a broader level, I think engaging with healthcare authorities is important because in many countries, availability of anabolic steroids are not restricted. In the United States, for example, it is very nicely controlled in terms of prescription androgens. So when we prescribe testosterone, we can only give it for 3 months, and then the pharmacy sends us a request for renewal, and we keep on renewing it for our patients who truly need testosterone. But it can easily be obtained from compounding pharmacies. Sometimes various gyms and the coaches have access to these compounds from other underground pharmacies. And also many nutritional supplements that are being sold are also not regulated, and many of those agents are being promoted as having anabolic steroids. So that is something which policymakers have to take action to make sure that there is some oversight. So we can warn our patients, we can educate them, and then having a conversation with the policymakers so that there is more control on the distribution of these agents.
Excellent. This brings me to perhaps a clinical, more of a clinical question and discussion, because you see those people coming with gynecomastia, and this is a very challenging problem. How would you approach this problem when it comes to your clinic?
In particular, gynecomastia?
Yeah.
I think it is, of course, an issue in those men who are using aromatizable androgens. So androgen abuse is basically a variety of androgens that many of these patients use, and sometimes multiple agents at one time. If you are using testosterone per se, which is aromatized to estradiol, high levels of testosterone will result in higher circulating levels of estradiol, and that triggers gynecomastia. Sometimes when patients are taking non-aromatizable androgens, perhaps the incidence of gynecomastia may not be that high. So here, of course, a purist approach would be to ask them to stop taking it, because that is induced by this overuse of androgens. I think if gynecomastia is significant, bothersome, and the patient is not willing to discontinue, then for symptomatic treatment, not an ideal situation, but for symptomatic treatment, tamoxifen is one thing which we use for gynecomastia of other reasons as well. So I think that would be one medication that one could potentially suggest. Tamoxifen is a SERM, and with all SERMs there are also side effects in terms of venous thromboembolism. So on one hand they are taking high doses of androgens, which are risky, and then if we prescribe tamoxifen, which also has cardiovascular side effects, we do not know how their risk profile gets worse. But that is one option that one could potentially consider in men who are clearly saying that they are abusing anabolic steroids, they don't intend to stop, and they have considerable gynecomastia which is symptomatic. Tamoxifen could potentially be considered.
Excellent. Another area that I'd like you to touch on is, do you think that testosterone available in the market, I mean not the prescribed one, regulated one, is it really pure testosterone or mixed with other hormones, growth hormones, something else as well? And the other perhaps challenge is that if someone has been using the anabolic steroid for quite some time, years, can they stop it immediately, or do they go to withdrawal? So those are things that I'd like you to
Sure.
touch on them.
Indeed, if androgens are acquired from the market, not prescribed from the pharmacy, but from various stores and by compounding pharmacy, it is difficult to know the doses that are being sold as are actually the compound contains those concentrations. And this applies not only to various types of anabolic steroids that are sold in an uncontrolled fashion, but also some of the other agents such as DHEA. So there were studies done in the past that investigators had bought DHEA bottles from various stores where it was being sold at on the label it would say 50 milligrams of DHEA, take one pill daily. But when they analyzed the compound in their lab, concentrations varied widely from 0 milligrams to as high as 1,000 milligrams. So if it is not prescribed and dispensed by appropriate pharmacies like we do in our clinic patients, you run the risk of buying agents which are not controlled, and the concentrations may not be what is mentioned on the package. Now, in terms of patients who would like to stop anabolic steroids, how to discontinue treatment. And I think it depends on what the patient is capable of enduring. So you can warn the patient that if you stop completely, which I do sometimes with my patients, the symptoms of resulting hypogonadism, because their axis is suppressed, could be significant initially. But the only way to hasten the recovery of the axis is to stop completely so that there's no negative feedback. Patients who are able to tolerate that, I think it would be absolutely fine to discontinue. But there are patients who will say that they fear that if they stop completely, they will become profoundly hypogonadal, symptomatic, and they may not be able to function properly. In those patients, it is appropriate to taper it down slowly. We discussed yesterday that the normal replacement dose of testosterone in a young man, if they are getting injectables, is 100 milligrams weekly, or in an older man, 70 to 75 milligrams weekly. Men who abuse anabolic steroids may be taking as much as 1,000 milligrams weekly.
That's
So
a
in them,
very huge dose.
slow tapering might be prudent to bring it down initially to a little bit less supraphysiologic, and then ultimately try to bring it down to replacement dose and then discontinue. So it all depends your relationship with the patient and what they are willing to do.
Sure. What do you think about the role of education and campaigns to highlight the challenges of this problem and how to come up with solution? Because the majority of impacted people are the younger individuals, younger generations. What do you think about those opportunities?
Incredibly important. We can educate in our clinic, but that is one-to-one. So you are able to hopefully influence the mind of one individual. But the same discussions that we can have with our policymakers to regulate underground pharmacies and regulate all these supplements, one should also have a discussion in terms of wider educational campaigns that can happen either via television, radio, various advertisements, various health seminars. So I think that would be important because the target audience would be very wide. But we need help from our policymakers and government to do that on a wider scale.
Absolutely. Now, you gave some take-home messages for the individuals using or abusing the anabolic steroids, the stakeholders, government. What about the clinicians? What take-home messages would you like to convey to the clinicians?
I think take-home messages would be for them to recognize the health consequences of anabolic steroid abuse so that they are able to convey it clearly to their patients. In addition to that, it is also important for them to be astute in terms of diagnosing a patient appropriately. Because many men who would like to have prescription from a doctor, many patients who have abused anabolic steroids, what they often do is they may pause taking testosterone so that their own axis is suppressed, and then they are often seen in endocrinology clinics for hypogonadism. And there is no clear-cut pathologic etiology for their hypogonadism. And one thing that the clinicians can think about, which is very simple but extremely important, is that there's incongruence between the hormone levels in these individuals and their phenotype. Because they are well built, they are muscular. That's not the profile of a hypogonadal man. Because men with organic hypogonadism, we know that their profile is quite different. So it is important to see that. It is important to look for acne on the back, on the shoulders, oily skin, and some very simple laboratory tests that one can do to try to see or get an indication whether they may be using anabolic steroids. And one is hematocrit, because most of the time hematocrit is high in these patients, and that's not a profile of organic hypogonadism where patients usually have anemia. Also, HDL is a very good indicator because exogenous androgens and high concentrations can suppress HDL, and also SHBG levels can give some indication because they are suppressed as well. So I think the clinicians need to first know the consequences of anabolic steroids so that they can convey it to their patients, but also should know how to diagnose it and use more common sense medicine to figure out who is truly hypogonadal versus the individuals who are in between cycles of testosterone for abuse, but seek care in your clinic for hypogonadism.
And I guess we'll come back to the societies and associations like the one, Emirates Endocrine Diabetes Society. What role the society has to take in order to address this challenge? You think flyers, websites, educational materials?
Sure. I think organizations such as EDEC can play a very important role in the Gulf. And yourself, Dr. Alwadi, Dr. Al-Kabi, can take a role in the sense that in future conferences, we do have dignitaries from UAE who spend some time to come and meet with us. Perhaps there could be a session on anabolic steroid abuse where from Ministry of Health, dignitaries could be present for that one lecture so that everyone becomes aware of the magnitude of the problem. They become aware of how it could be prevented. And I think that would perhaps be a very good step from a joint campaign from the clinicians, the scientists, as well as from the ministry to work together to address this issue.
This is a very nice idea that you gave us. Actually, we covered this topic last year, but I think involving stakeholder might be the way forward to address this problem.
Indeed.
And ensure that we monitor the issue, see the progress, are we improving on our initiatives to address the problem or not. I think we're coming close to the conclusion. I don't know if you have specific information, messages that you'd like to share before we come to a conclusion.
Yeah, I think reading about this topic is extremely important for endocrinologists in particular, but also general practitioners in general to understand the magnitude of the problem, presentations of the patients, and how to go about counseling them and managing them. I think this would be a step forward from at least our side, the scientists, and hope that in the future we collaborate with industry and also with health ministries to have a sort of a combined effort in curtailing this problem.
At the end, I'd like to thank you for joining me in this podcast. We enjoyed the talk, and I think there are several messages that we could convey to our patients, our clinicians, and also our regulators. Thank you very much, Professor Basaria, and wish you a successful stay and enjoying the conference as well.
No, thank you very much for inviting me to this podcast to address a very important problem, and I always enjoy coming to EDEC. As I mentioned, that this is one of the anchoring meetings in this part of the world which is expanding, so it's great to see its growth and how it is evolving.
Thank you very much.
Thank you.